Hello and welcome everyone to our second part for the GU pathology section for peer-to-peer path. In this section, I'm going to cover the bladder tumors, which is our second topic in terms of the GU path. Then we'll go over the kidney tumors and the prostate tumors, and we'll do some virtual microscopy at the end of the section so that we try to recall the different entities which are high yield for the boards. So going over the bladder tumors, bladder tumors is a relatively flat topic. What I mean by a flat topic is it doesn't have this like isolated histological patterns that you need to identify. It's more of a grouping way or a grouping patterns. What I mean by grouping is that you have flat lesions, then papillary lesions, in which you have an approach. There is an approach for flat lesions, an approach for papillary lesions, and then there is like other epithelial lesions, and of course the urothelial carcinoma, which with its different patterns. However, the same thing will happen in the kidney tumors. Like when we talk about the kidney tumors, you will see that the kidney tumors will be subdivided into eosinophilic cancers, which have kind of eosinophilic cells, and then basaloid cancers, which have a kind of blue cells, and clear cancers, which is a kind of clear cells under the microscope. So it's kind of a grouping patterns or a grouping approach. The same thing will be happening in bladder tumors and bladder pathology. As I said, I'm gonna include this email in all my videos. Special thanks to Dr. Kurt, who taught me pathology without even meeting him. So let's start by the outline of our lecture. We'll start by talking about the normal anatomy or the normal histology of the bladder, and then we'll move on to talk about the non-pathological lesions. I don't mean non-pathological here. I mean non-neoplastic lesions and then neoplastic lesions. This is kind of inflammatory lesions. So let's talk about the normal anatomy of the bladder. The bladder, as we know, is having this transitional epithelial lining. It has layers. The layers include epithelium, which is actually a transitional epithelium. And then we have the lamina propria, and then some kind of thin muscle fibers here, which we call the muscularis propria, muscularis mucosa. These are the thin muscle fibers right there. And then we have the musculosa, or the muscularis propria, which are thick muscle bundles or thick smooth muscle bundles of the detrusor muscle, which when it contracts, the bladder evacuate or empty the urine. This is the detrusor muscle, which is a smooth muscle. And then you have the outermost layer, which is the adventitia. So we have epithelial layer. The epithelial layer is the urothelium. The urothelium is usually having a normal thickness of 2 to 7 cells. Why this high degree of variation? Because the bladder is a distensible organ. It fills up with urine and it distends. So when the bladder is full, as you can see here, the lining will be like kind of 2 to 3 cells. However, when the bladder is empty, non-distended bladder, the number of cells in the lining increase to 5 to 7 cells. And that's a characteristic of transitional epithelium usually. So we're talking about the transitional epithelium. We have the three flavors of cells, which are the basal and then the intermediate layer, and which are often cuboidal to columnar. And then there is a surface layer of umbrella cells. So you see here, you see this basal layer. I'm highlighting one cell right there, which is usually more towards the columnar. And then you sometimes, especially in the non-distended bladder, they appear more, which are the intermediate layer. I'm highlighting one of the cells here, which is a kind of polyhedral or cuboidal slash columnar. Why I'm saying slash columnar? Because a cell like this look more like a columnar. And then you have the superficial layer. The superficial layer has a very, very important cell, which kind of look like an umbrella. It's like very like looks like a cloud like this. That's why they call it umbrella cells, which are the surface cells. Here it is, the top umbrella or superficial layer of cells. These are kind of large, and sometimes you see some accidental binucleation in this layer, which you should not be concerned about. There is always a eosinophilic cytoplasm, and sometimes the cytoplasm is vacuolated. However, this is the transitional epithelium, non-distended, distended, and the number of cell layers. Then you have the lamina propria. The lamina propria is the layer of connective tissue. The connective tissue always contain blood vessels, nerves, and vessels, blood supply, nerve supply, lymphatic vessels, connective tissue elements, blah, blah, blah. And then you have the thin layer of muscle, which is called thin interrupted smooth muscle fibers, which exist in the lamina propria layer. These are called the muscularis mucosa layer. Why am I stressing on that? Because you should be able to differentiate between the muscularis mucosa layer, which is thin, interrupted, smooth muscle fibers existing in the lamina propria, and the thick muscularis propria layer, which is composed of organized, thick bundles of smooth muscles. Why am I stressing on that? Because we will have urothelial carcinomas, and we need to identify muscularis propria invasion, which is crucial in terms of the management of the patient. So you don't need to end up confusing an invasion of just the thin interrupted muscles. If you see some here and there thin muscles and you say, oh, there is muscle invasion. No, this is just muscularis mucosa. So if this is invasive, it will be invasive in the lamina propria only. However, to clearly tell that there is frank muscle invasion, the tumor cells must exist between these thick organized bundles of muscle to say that there is a muscularis propria invasion or detrusor muscle invasion. And then you have, of course, the outer layer, which is the adventitia. So let's talk about some non-pathological variants. What I mean by non-pathological is that there is no pathology here. This is just physiological change. You cannot even call it an inflammatory lesion, for example, or anything. This is just some things which, or some changes which exist physiologically. Like you might see some detached transitional lined nests existing in the connective tissue or in the lamina propria of the bladder, and they are called von Brunn nests. Von Brunn nests, as you see highlighted here, they are invaginations of the superficial uroepithelium or of the surface uroepithelium. They exist in the lamina propria, and they are usually uniform in size. Like you feel like you kind of have a large size, medium size, small size, like 3 flavors here, and they are repeating themselves. You should be able to differentiate between von Brunn nest and something that I will call, or something that I will explain later, which is the nested variant of urothelial carcinoma. You should consider that. When should I consider a nested variant of urothelial carcinoma? You see a lot of crowding. They look like islands, isolated islands. This is what we call von Brunn nests. But if you see crowding, they are packed to back and they are very crowded. Some kind of atypia in the cells existing. Oh, you might consider either a nested variant of urothelial carcinoma or other entities that I will cover later. So these are small nests, irregular in size. They are stacked on top of, if you see lots of small nests, irregular in size, and they are stacked on top of each other, very crowded, considered nested variant of urothelial carcinoma. However, the von Brunn nest usually aligned by normal uroepithelium, normal in thickness and normal in cytology. You don't see any abnormal cells or any suspicious cells right there. Some of these von Brunn nests might undergo some cystic changes, as you can see here. And in this case, we call it cystus cystica. The nests become cystically dilated and some cystic changes. And sometimes you might see, like what you see right here, it's kind of mucinous lining. Some cells in the von Brunn nest undergo some glandular or mucinous metaplasia. This is glandular metaplasia, glands, like the cells become having some mucin inside, intracytoplasmic mucin. This is what we call glandular metaplasia, and sometimes they call this cystis glandularis. So we have von Brunn nests, cystis cystica, and cystis glandularis. All these are normal, non-pathological, physiological changes. You shouldn't even consider this a disease or a pathology. Then we're going to cover some of the non-neoplastic lesions that were encountered in the Q banks for the boards. The eosinophilic cystitis is one of the commonly asked entities in the Q banks, and the striking finding here is when you go by endoscope, they tell you that the endoscopic findings show like inflamed lining of the urinary bladder. The lining is inflamed. And then the oil, we took a bite, and here is how it looks like under the microscope. You see a lot of crowded eosinophils everywhere. A lot of eosinophils. See, all of these are mainly eosinophilic inflammation. And sometimes in the same picture, you will see these eggs. These eggs, the eggs are usually creating some kind of a nest for itself, or a cyst, or a kind of a space surrounding the egg, and then they are surrounded by the whole bunch of inflammatory cells, which are mainly eos or eosinophils. These eggs are the eggs of the schistosoma, mainly the type which exists in the urinary tract, which is schistosoma hematobium. Sometimes they ask which kind of schistosoma it is, whether it's schistosoma hematobium or schistosoma mansoni or mansoni. The mansoni is in the GI, so please remember that. The mansoni is in the GIT, so the hematobium is the one in the urinary tract and exists in the bladder, as you see right there. So it's very uncommon in the US because it's more common in the developing countries. So you might see some keywords in the question saying that this is an immigrant or a US citizen who traveled recently to the Middle East or Africa, where he got the infection. It clinically sometimes mimic urothelial carcinoma with that much extensive inflammation. You might think about stroma reaction or anything. However, I'm telling you that there is usually endoscopic finding of ulcer, inflammation in the bladder lining, and the main thing is high eosinophils or eosinophil mediated inflammation. And usually in the picture you will see the schistosoma eggs with that terminal spine, which is usually like that. This is the schistosoma eggs and how it looks like. The mansoni, this is the hematobium. The mansoni egg usually has this characteristic lateral spine. This is the mansoni, and the hematobium usually has a terminal spine. You remember that I always say mansoni has a lateral spine, and the hematobium is the one which has a terminal spine or spine facing downwards. Some late changes that might happen with chronic infection. that the eggs might calcify, and the inflammation might heal by fibrosis. So there would be an extensive fibrosis, and in this situation, it's extremely difficult to diagnose because you don't see that much eosinophils in the background and you don't see the eggs there. This is the brief life cycle of the schistosoma. You don't need to know that in details, but you need to know that the infective stage or the infectious stage of the schistosoma is the cercaria. The cercaria is the one that emerge from the eggs after they hatch and form this miracidia. They live for some time in the snails, and afterwards they become an immature form swimming in the water called cercaria, and this cercaria is what penetrates the skin when you're swimming in these like lake water or these waters. When you're swimming, it penetrates the skin, and this what causes the infection, and it leads finally to a urinary tract infection with the schistosoma hematobium and GI infection in schistosoma mansoni. Just the eosinophilic cystitis. Another type of cystitis, which is also asked in the questions, is the interstitial cystitis. Interstitial cystitis is a kind of a thing which we always say it's a diagnosis of exclusion. Why we say it's a diagnosis of exclusion? Because all what you will see under the microscope here is a kind of chronic inflammation. But I always say it's a kind of extensive chronic inflammation. What I mean by extensive chronic inflammation here is you see numerous mast cells, also lymphocytes, some macrophages, like right there. Here are lymphocytes. So a lot of lymphs, a lot of macrophages, and a lot of mast cells. And sometimes they say that by text. They don't even show you the picture. There's a lot of mast cells under the microscope. So it's edema and congestion in the lamina propria, or inflammation in the lamina propria, with multiple mast cells throughout the lamina propria muscularis propria. You have to correlate this with endoscopic findings, and they would never give you a case of interstitial cystitis without telling you that the patient cystoscopically on endoscope had significant inflammation and significant ulceration of the lining of the bladder. So this is very important because this is what we mean by clinical criteria. The diagnosis here you cannot rely only on the pathological image or how the H&E section look like. You have to correlate clinically with an abnormal endoscopic finding of inflammation and ulceration in the lining. Usually in this case, you have chronic cystitis, as I mentioned. Usually there is no infectious organism involved. It's culture negative, and it's highly more common in females for some reason. This is what we call interstitial cystitis. So what's characteristic here? There are two things that you see here in this H&E. It's this kind of polypoid configuration. You see polyps, or they are not true polyps. They are just polypoid architecture. And then you see this significant congestion in the lamina propria here. See the congestion involving the vessels. They all say that at the garden of roses. Feel like as if there is a garden of roses in the lamina propria. That's what we call polypoid cystitis. So if you see this garden of roses and you see this polypoid architecture and chronic inflammation, so we are dealing definitely with a case of polypoid cystitis. The polypoid cystitis is, as you see, submucosal edema, fibrosis, and chronic inflammation with lymphocytes, macrophages, blah, blah, blah. And you have some kind of broad bulbous projections covered with reactive epithelium. The epithelium here might be reactive to the point that you might suspect that you're dealing with any kind of CIS or carcinoma in situ or anything. However, there is no true polyps. This is just a polypoid, no epithelial branching, nothing, no atypia, no signs of invasion, no malignancy, and it usually happens as a reaction to an inflammatory insult. Like they will tell you that this patient had a prolonged catheterization or a prolonged indwelling catheter. In this case, you see this histological image, garden of roses, polypoid architecture, chronic inflammation. Boom, that's a classic case of polypoid cystitis. So how many types of cystitis we covered? Please remember that. High eosinophils, high eos, plus or minus eggs. This is schistosoma. It's eosinophilic cystitis. And then chronic inflammation with mast cell. This is what we call interstitial cystitis. Polypoid, garden of roses plus chronic inflammation. This is polypoid cystitis. These are the three most common types of cystitis which always exist here and there in the Q banks for the boards. Now let's move on to the main action here, which is the neoplastic lesions or the cancers. We start by saying some general rules that you have to know or you have to be oriented. Cancer is a disease of the old age. They usually happen in the old-aged males. The bladder cancer in specific is obeying the general rules for the risk factors for cancer. I would say what causes the cancer, say smoking, old age. These are the common or the general risk factor for any cancer. However, bladder cancer in specific has a significant occupational risk in place due to occupational exposure to some kind of paints and some kinds of exhaust, like the benzene and the benzene and the gas exhaust in the gas stations. This also related to bladder cancer, and exposure to radiation, also chronic inflammation due to schistosoma hematobium. It usually present with blood in urine, hematuria, always hematuria in an old-aged male raise the risk for bladder cancer. 90% urothelial carcinoma exists in the urinary bladder. 10% it might exist in the upper urinary tract, like in the ureter or in the renal pelvis. It's usually multifactorial. However, there is a high mutation rate. There is always a mutation in the bladder cancer and the urothelial carcinoma. And if we enumerate how many genes or how many oncogenes are involved in bladder cancer, you might enumerate everything you know. Any oncogene that you know or encounter in the pathology curriculum for the boards, you might hit it. Like TP53, FGFR3, TERT promoter, PIK3CA, which is the PCA. We always say PCA. RB, RAS, any oncogene that you imagine is always there in bladder cancer. So it shows a very high mutation rate and a high incidence of loss or gain of some chromosomal fragments, as well as mutations in some oncogenes, including TP53, FGFR3, TERT. These are the three, by the way, most common tested ones, especially the two which have the three, which are the TP53 and the FGFR3. The two which have the number 3 are the most commonly tested ones, the TP53 and FGFR3. Bladder cancer is highly associated with Lynch syndrome, which is also associated with GYN cancers and colon cancers. We will talk about that later. And here we go. We have two parent families for bladder tumors or bladder cancer. And this is the first step you need to do when you see some atypical or suspicious or malignant cells. You need to see whether you're dealing with a flat lesion, which is flat, or you're dealing with a papillary lesion, which projects as papillae. So it depends. Two main categories, parent categories exist here, flat and papillary. Here is the flat lesion. Let's start by talking about flat lesions, which are the carcinoma in situ and the flat urothelial carcinoma. When talking about the flat and the papillary lesions, we'll first talk about the non-invasive ones, which I mean that you see the malignant cells or you see the malignant changes, but there is no invasion or no lamina propria muscularis propria invasion. Otherwise, it's going to be like either invasive lesion or your invasive urothelial carcinoma, whatever we will discuss later. Let's start with the flat ones. The flat ones, the key flat lesion is the carcinoma in situ, which is the CIS. In the CIS, well, I don't see any papillae, so I'm dealing with a flat lesion, no papillary structures, and then you see this high-grade cytology. High-grade cytology means that you're seeing atypical cells. You see the features of high-grade cytology, including nuclear pleomorphism, cellular pleomorphism, and high NC ratio. This is what I mean by high-grade cytology. And then when you look at how the urothelium is organized or the epithelium is organized, there is loss of organization of the cells. This is what we call the loss of polarity or disordered polarity and crowding of cells on top of each other. In carcinoma in situ, these kind of atypical or malignant cells, they are usually very discohesive to the point that they shed down in the urine, and this lead to positive urine cytology. This we will cover later in the cytology section. However, the key question mark that you need to find an answer to when you look at this slide is whether this is a true carcinoma in situ or is it just a reactive atypia, what we call reactive atypia, or is it just reactive changes? Reactive changes usually happen in response to chronic irritation, like having prolonged catheterization, having some kind of chronic cystitis going on. This might lead to some reactive changes in the overlying urothelium. So I wanna now confirm whether this is a CIS or a reactive. What we do is immunohistochemistry. This immunohistochemistry panel is commonly tested in the wards and is commonly asked in the QVACs. So the IHC to differentiate CIS from reactive include CK20, P53, and Ki67. If you remember when we talked in the introduction part in the general rules, we mentioned that TP53 is usually mutant or mutated in the carcinoma pathway or in the bladder cancer. So P53 is a very good stain. When you see like the wild type panel, the wild type pattern is the isolated positivity, like some positive cells here and there, and other cells are negative. This is what we call the wild type. This is CIS, this is reactive, and when you see the mutant pattern is either having no staining at all, which is called the null type, or having diffuse strong positivity to the point that all the cells are taking over the stain. This is what we call the diffuse P53 or null P53 type. This is the mutant pattern. The mutant pattern is a kind of a carcinoma in the carcinoma pathway, so it's more towards the CIS rather than being reactive. So P53 is very important. CK20, you're looking for umbrella cells. CK20 usually stain the umbrella cells. We always say the umbrella cells are very large, so it's stained by a large number CK, which is CK20. So CK20 stains the umbrella cells only in case of the normal or reactive. You see the superficial umbrella cells getting stained. However, in the CIS, you'll see that the CK20 is staining actually the whole entire thickness or the full thickness of the epithelium. This is because most of the urothelial carcinomas are usually CK20 positive. Ki67 is the proliferation index, so it will be high in the pre-malignant lesion, which is the CIS, and it will be low in the reactive because it's still normal. Another stain that is not mentioned here in this table, but is very important, frequently tested, you should add it to the notes, it's CD44. CD44 is another important IHC to differentiate reactive from CIS. is usually positive in reactive and negative in CIS. So this is a good stain. You know why? Because it's like a negative positive stain. It's like P53. P53 also is a wild type mutant. So this is very easily interpreted. Also CD44 is either negative or positive. Negative in CIS, positive in reactive. So I'm sorry, I put it wrong. Positive in reactive and negative in the CIS. This is what the CD44. Carcinoma in situ, in case you confirm the diagnosis that this is carcinoma in situ, it's 25% might progress to invasive disease or invasive urothelial carcinoma. That's why we need to observe by cystoscopy, and we might inject BCG as a way of treatment. That's the only flat, non-invasive lesion in the bladder. What about this one? Urothelial dysplasia. Forget about it. Forget about it. See, it's not diagnosed routinely in clinical practice. This is like a kind of unqualified CIS. Like it's a kind of dysplasia. There is dysplasia going on, but it does not qualify to call it as a frank CIS. So this is when we call urothelial dysplasia. Sometimes they say reactive changes with urothelial dysplasia. This is when you want to stay in the gray zone. So these kind of things never be tested, rather neither in the Q-banks nor in the boards. So the papillary now. Papillary is very important. So you see papillary architecture, which is papillae, finger-like projections. To call something a papilla, we need to have blood vessel here, a feeding vessel, which is the fibrovascular core. And then we have epithelium there. That's why when you take a cross section there, there's usually this blood vessel in the middle, and the epithelium is all around right there. This is a cross section, and this is how it looks like when you see the full finger. So it has this fibrovascular core and a branching architecture or finger-like architecture, and the covering epithelium, of course. So this is an excellent algorithm, also from Kurt notes, and it's coming from the WHO classification of the urinary system, male genital systems 2016. This is how you can approach any papillary lesion in the bladder. So you should look at a medium magnification. Don't look at very low power, don't look at very high power, look at a medium magnification and see what's your overall impression. You should comment or look at two things. Look at the order of architecture and the cytology, how the cells are arranged. Are they well arranged or they're here and there? This is what I mean by order of cytology. And order of architecture. Order of architecture means, do you see like a finger like this? Or do you see a finger with branchings like this? This is what I call the order of architecture. So is there any variation of architecture and cytology? If no, you're dealing with a pun lump, and I will say what's pun lump. And if yes, it's papillary urothelial carcinoma low grade because it's still like organized cytology. There is variation in architecture and there is variation in the cytology. However, it's still low grade. If you see like this order of architecture and this order of cytology, so you are dealing definitely with papillary urothelial carcinoma high grade. So let's move on and talk about the papillary lesion one by one. So here, what do you see? Well, I see fingers. Okay, I see papillae. But the papillae are more like a tree. I always say that. The papillae here are not fingers. These are not finger-like. They're more like tree branches. Very branching, tree-like, arborizing. This is what we call arborizing papillae or arborizing architecture. This is what we call the papilloma. So papilloma, you'll see the fibrovascular cores and urothelial covering. And when you look at the urothelial covering, you will see that this urothelium is purely normal. normal in appearance, normal in thickness, nothing abnormal about it. But you see this arborizing architecture and you see this tree branching. It's relatively rare, not related to HPV, as you might expect. However, you need to mention in a comment when you say that, well, I see urothelial papilloma, or I see a papilloma, urothelial papilloma. You need to say, well, urothelial papillomas are associated with approximately 10% recurrence rate and 1% transformation to a carcinoma, so that the clinician or the urologist know that he need to follow up. Still, he need to follow up this patient, because some clinicians have this kind of impression, which is, oh, well, papilloma is benign, so you go home. No need even to follow up. No, there is 10% in urothelial papilloma has 10% recurrence rate and 1% progression to carcinoma. So you still need to follow up your patient. So papillomas, see that? Arborizing architecture, normal urothelial covering with fibrovascular force. Finger-like, arborizing, finger-like, arborizing. Please memorize this kind of pattern. So this is finger-like. Okay, so I see finger-like architecture here. So I'm dealing with papillary urothelial neoplasm or papillary urothelial carcinoma, whether it's low grade, high grade. So what's the next step? The order, is it organized or disorganized? And the cytology. Let's look at the order. Here it's more organized. See, the layers are streaming over each other and is still organized. This is in terms of order or organization. In terms of cytology, when you look at two high power fields, if you go in two high power fields in any area of this papilla, you see that you're seeing identical cells or identical architecture or identical cytology. Cytology is very bland looking, very, very, very low grade, to the point that you might say, this is just an increase in the thickness of the urothelium without any change in any cellular morphology or any cytology. So this is when you call PUM lump. PUM lump. PUM lump stands for papillary urothelial neoplasm of low malignant potential. So you're seeing minimal atevia, barely any. The epithelial thickness is usually thick, to the point that you feel like this is just a thickened urothelium forming some kind of finger papillae. There is order, organization, and there is little variation, to the point that you feel like any high power field look like the other. It's mirror image. This we call monotonous appearance. Okay. So this we'll call it PUM lump. Why don't we call it papillary or low-grade papillary urothelial carcinoma? Well, sometimes this is a gray zone. You might see some variation between pathologists. Like some pathologists will call it PUM lump, and another pathologist, oh no, I feel like this is more disorganized by a way or another. I feel like the cells are atypical a little bit. So let's call it papillary urothelial carcinoma low grade. That's why it's usually IDC4 or interdepartmental consultation, in which all the attendings usually agree on one opinion. And luckily, there's no difference. See, it's often hard to distinguish from low-grade papillary urothelial carcinoma. However, there's no difference. The treatment for both of them is TURBT, so an observation. So there is not really much difference when you call it PUM lump versus low-grade papillary urothelial carcinoma. There is a low recurrence risk and low risk of progression to carcinoma here. Here is this is what the key difference for me between papillary urothelial carcinoma low grade and PUM lump. See the surface of the finger. See the surface of the finger here is more smooth appearing. But see how the surface of the finger here is more irregular, as if there are fingers on top of the finger. That's what I usually look at in terms of low-grade papillary urothelial carcinoma. But still, you see increase in thickness of the urothelium. You still see order, arrangement, or still the epithelium is organized, There is cytological atypia, however, not significant atypia. How do you determine that there is no significant atypia, whether you see mitosis or not? Believe me, this is the key thing. Look for mitosis. If you see a lot of mitosis, which is very obvious to whoever is even blind, even a blind person can see these mitotic figures. So you're dealing with high atypia or high grade cytology. So might think about calling it papillary urothelial carcinoma high grade. However, here you don't see that much mitosis. However, you see some cytological atypia. This is what we call low-grade atypia. Still, there is order, there is organization, and there is increase in urothelial thickness. Let's preview. See, extensive branching. This is what I mean by the fingers on top of fingers. Orderly. There is some variation at the high power. It doesn't feel like here is like there. There is some difference at low power. There is some mild to moderate nuclear pleomorphism. However, the cell polarity is maintained and no prominent nucleoli, no mitosis. Here, it's non-invasive papillary urothelial carcinoma low-grade or low-grade papillary urothelial carcinoma. Here, the recurrence rate is higher a little bit. It's 30%. However, it's treated the same way at the pun lump by turbidity and surveillance. Here's how a high power of a high-grade papillary urothelial carcinoma look like. A high-grade papillary urothelial carcinoma will have the same finger with the same fingers on top of the fingers. However, when you look, there is increase in thickness in the urothelium. However, there is no organization there. The cells are on top of each other, not respecting each other, as you see here. All the cells are running in different directions. A whole bunch of different directions. And see how much pleomorphic the cells here. See, this cell doesn't look like this cell, and they both don't look like this cell. See this cell, so it's significant pleomorphism, loss of organization, prominent mitosis. This is high-grade papillary urothelial carcinoma. Disordered appearance, architectural-wise and cytological-wise, there is loss of polarity. All the cells are running in different directions, not respecting each other, jumping on each other. There is nuclear pleomorphism, hyperchromasia. Sometimes you see prominent nucleoli, and often you might see some fusion of the papillae and mitotic figures with much prominent mitosis. Here, the recurrence rate is even higher. It's 50%, not 30%. So you have 30%. Maybe here 10 to 20%, so 10 to 20, 30, 50. I will say 10, 30, 50, so that would make it easy. 10, 30, 50, 1, 3, 5. Okay. This should not be classified as a papillary lesion, actually, because here there's no papillae. There is no finger-like projections. But it's like, I would say, pseudo-papillae. Why I say pseudopapillae? Because there is no finger, long finger-like projections with fibrovascular course. It's just wavy mucosa to the point that it creates a false impression that you're dealing with papillae, but there is no papillae there. There is just thickening of the urothelial lining, increasing the number of cells in the urothelial lining. The normal urothelial lining should not be more than 7 cells. Here, there is definitely more. However, organization, yeah, they are organized. Polarity, yeah, they are polarized. Cytologically, well, there is no high-grade cytology here. Cells are very good, no pleomorphism, nothing. So this is what we call U-pump. U-pump means urothelial proliferation of uncertain malignant potential. So we here must comment on the differentiation between U-pump and the pun lump. That's very important. I will say the two umps. The two umps. U-pump, pun lump. U-pump, pun lump. How to differentiate them? There is true papillae. Fingers. Here, no true papillae. In both, there is thickened urothelium. In both, there is organization. In both, there is no loss of polarity. In both, There is no mitosis. In both, there is low-grade cytology, no high-grade cytological features. So this means that the key difference between the U-pump and the pump lump is whether there is fingers or not. See how this looks like? That's a finger, that's a papilla. But see here is just wavy mucosa. That's it. Undulating mucosal folds. No true papillary fronds. Marked thickening of the urothelium. No or minimal atypia. It might be that some people say that this is a precursor to low-grade papillary urothelial carcinoma, actually. Okay, we're still talking about the papillary lesion, but here it's not fingers to outside. These are fingers to inside. I always say these are inside papillae, inside papilloma, or inverted lesions, or inverted papillomas. That's what we call inverted urothelial papilloma. You feel like as if you are dealing with papillae, but the papillae are projecting to inside rather than projecting outside in the lumen. So these are crowded, complex, branching anastomosis cords of cells. See, these are the cords of cells, but they are too crowded to call it von Brunn's nests. Remember, let's go back. This nested variant of urothelial carcinoma, and I said also inverted papillary lesion. See, this is how von Brunn's nests look like. Very isolated, very far away from each other. Here, look at this, very crowded, very complex, very branching. However, they kind of look like nests, yeah? This is cords of urothelial cells. And if you look peripherally, you will see peripheral palisading or peripheral cells which are more of arranged beside each other, forming a palisade, which is called peripheral basal cells in the nests. Well, it's not really palisading, but there is some peripheral basal cells and some like complex branching and anastomosing cords of cells. There is no stroma reaction because here this is not invasive, it's non-invasive. Usually the most famous type of inverted urothelial lesion is the inverted papilloma, which you see here. It usually has some kind of between 5 to 10 cell layer in thickness. There will be no significant atypia and it's very benign looking with low recurrence risk. Sometimes this happened in one Q-bank. One Q-bank asked this question or had this picture with this classic picture of crowded nests, branching crowded nests. Well, I said, okay, this is inverted urothelial lesion, but I saw some areas of squamous cells. Am I dealing with invasive urothelial with squamous differentiation? This is like non-keratinized squamous epithelium. So I see like squamous epithelium in the middle. No, this is not. Non-keratinizing squamous metaplasia has been reported in inverted papilloma. Make sure you know that if you see some isolated squamous cells or isolated squamous metaplasia in the inverted urothelial papilloma, this is a pure normal finding, pure physiological finding. No need to worry about it, and no need to worry to call it inverted urothelial carcinoma. Because when I looked at this picture, that time I said, oh, there is no significant atypia here. I don't see significant pleomorphism. I don't see significant evidence of carcinoma. And there was no stroma reaction in the surroundings. So this is more towards the invert. But what are these squamous cells? Squamous cells turn out non-keratinizing squamous metaplasia. It's reported in inverted papilloma cases. Another thing that I need you to know that inverted papilloma, they call it also Brunnian adenoma or Brunnian adenoma. I don't know how it's correctly pronounced. However, this was there in one of the choices in the Q-banks and I wasn't able to get it. This is the same thing as inverted urothelial papilloma, just letting you know about it. So add this to your notes so that you know that they are both the same. this inverted urothelial papilloma might become inverted papillary urothelial carcinoma if there is invasion. And if the nests, they usually coalesce together or merge together, creating an impression that they are not nests anymore. They're like becoming one mass, one expansile nodular mass. So see, still see here nodular expansile growth. However, you still have the impression that these were isolated inverted nests and they kind of merged together. High-grade cytology is seen here. Stroma reaction is seen here sometimes. More mitosis, more atypia, significant cytological atypia with irregular chromatin, prominent nucleoli, and prominent mitosis, and the cell thickness usually exceeds 10 cell layer here because you are counting, oh, how many? This is nodular expansile, so how many cell layers? Definitely more than 10. So that's the inverted urothelial papilloma versus inverted urothelial carcinoma and the inverted papillary lesion. So let's summarize before I move on to the invasive urothelial carcinoma. So let's summarize the papillary lesions here. So the papillary lesions, we have the arborizing one, tree-like with no atypia. This is papilloma. We have finger-like, organized, no loss of polarity, no cytological atypia or mild cytological atypia. It's pun lump versus low-grade papillary urothelial carcinoma, which has fingers on fingers and grease thickness, organization, no loss of polarity, no mitosis, no significant atypia. If you see loss of polarity, significant atypia, and the same finger-like projections with fingers on fingers, this is high-grade papillary urothelial carcinoma. And if you don't really see through fingers, it's just wavy mucosa or undulating mucosal folds with the same features of pun lump. This is called U-pump, which is urothelial proliferation of uncertain malignant potential. Inverted fingers, inverted urothelial lesion, inverted urothelial papilloma. If there is no loss of polarity, still you see crowded nests, but they are still separate nests. No stroma reaction, low-grade cytology. High-grade cytology, expansile growth, and all of them united together or merged together, forming this expansile growth mass with a very thick count of cell layers, more than 10 cell layer thickness, and you see some stroma reaction in the surrounding and high-grade cytology features. So you're dealing with inverted papillary urothelial carcinoma. Okay, let's now talk about the invasive urothelial carcinoma. At this point, we'll take a break before starting the frank invasive urothelial carcinoma, which is a totally different entity rather than the flat and the papillary non-invasive lesions. However, before we go on this break, let's do the brainstorming for what we covered as entities in bladder pathology. So, if we're having inflamed bladder lining with high amount of eosinophils and plus or minus some kind of calcified eggs, this is eosinophilic cystitis or schistosoma hematobium. If you're seeing a whole bunch of chronic inflammatory cells, mast cells, lymphocytes, macrophages, fully crowded, this is interstitial cystitis, and this needs cystoscopic correlation with ulceration and inflammation. If you see flat lesion, no papillae, no inverted papillae, it's just flat dysplasia in the covering urothelium, you're dealing with either CIS or reactive changes. In this case, you do P53, you do CD44, you do CK20. The CK20 will highlight the umbrella cells in the normal/reactive, and it will be diffusely positive in case of CIS. The TP53 will be wild type in case of reactive, and it will be mutant, which is either null or diffuse in case of CIS. CD44 is usually positive in reactive slash normal and negative in the CIS. In papillary lesions, we look for whether it's arborizing like a tree. This is papilloma, urothelial papilloma. There is recurrence rate and there is 1% risk of carcinoma, so the patient need to be followed up. Please don't let him go home and never come back. There is, however, still the urothelium is organized, no atypia, nothing, no abnormal cytological features. And you might see finger projections or finger lesions, which are papillary urothelial lesion. The papillary urothelial lesion could be pun lump, U pump. What's the difference between pun lump, U pump? Undulating urothelial mucosa. There is no true papillae. However, here there is true papillae. There is true finger-like lesions or finger lesions. In both of them, there is no loss of polarity. There is organization. There is no high-grade cytological features and no mitosis. However, if you still see a pun lump-like picture, which is finger-like projection with small fingers on top of the fingers, and you still see thickening of the urothelium, still organization, there is organization, no loss of polarity, no high-grade cytological features, no mitosis, so you might be dealing with low-grade papillary urothelial carcinoma. And I always say that there is a kind of overlap between the pun lump and low-grade papillary urothelial carcinoma, but both of them will be treated by TURBT and follow-up. So no pain, no problem. However, if you see high-grade cytological features and there is loss of polarity, but still you see the fingers and the fingers on top of the fingers, and there is high mitosis, so you're dealing with high-grade papillary urothelial carcinoma. Then there is the inverted papillary urothelial lesions or inverted urothelial papilloma, which are the nests. The nests show peripheral organized cells, and there is like nearly 10 cell layer. These nests are closely packed together, so you cannot call them von Brunn nests. These are called inverted urothelial papilloma. No significant cytological atypia, no stroma reaction, no invasion. However, if these nests coalesce together or merge together and form an expansile lesion with very significant increase in the thickness of the urothelial layers, more than 10, and high-grade cytological features, prominent mitosis, and some stroma reaction, so you're dealing with inverted urothelial carcinoma. That's what we covered until now. See you later in part 2. Take 15 minutes break.